Good evening, sir.
Hi, good evening. Fresh. Garden fresh. The clinic fresh.
Thank you, thank you.
Are the co-chairman and moderator, etc., are there, and panelists? I could see the convener. Yeah, Dr. Sudeep is there, the co-chairman.
Yes.
Okay. What
Good
about
evening.
Dr. Good evening. Good evening. What about the Madhu Udaraju?
Yes, sir. Namaste, sir. This is Dr.
Namaste,
Madhu.
namaste. Oh, you are here. Good.
Yes, sir.
And above all, where our Professor Mohan Rajan? Sir, show your face.
I think he's elsewhere. I think he's got an award. He's getting an award at the same time.
Oh, I see.
So he will join later.
Later, okay.
Okay.
Few of our panelists are outside Odisha, but still they promise to join.
Yeah, I am at present. I am Modia, but I'm at present in Vellore.
I know that. I know. No. But
No,
staying in
I'm just
Odisha-
reached Vellore today.
I know,
reached
sir.
Vellore
That
today.
is
Yeah.
the greatness. But thing is that in Odisha it is being organized, and the people
Yeah.
have gone outside Odisha for
Yeah.
this Andaman Nicobar. So they
Yeah.
may not be there. They told us to join. Let's see if they can.
Good evening, Dr. Madhu and Dr. Sudeep.
Good evening, sir. Good evening, sir.
Sudeep sir, how are you?
I'm all right. I'm absolutely all right.
Yes. Happening to see you back.
Yeah.
Yeah, nice to see you back.
Yeah, 7 months in
Yeah.
different world altogether. Then I was
People of
back.
Parampura missing you.
Yeah. Anyway, good that I'm all right, because I know in December and all I used to do 10 surgeries and I used to be so exhausted and I didn't know why. I thought it was because I was becoming old. Seriously. And
So
then
it is a mental health,
yesterday
not
I think
physical
I
health.
did some 35 surgeries and then drove myself to Cuttack. Stayed the night there, and I was absolutely all right. I was so
Great,
I would
great.
really thank God for that.
Great.
That rhythm would
Un-
definitely slow down with the age, but still the
No,
mind
no,
is
this
there,
is
so
because
you
of the
can say
disease,
anything.
not because of the age.
Yeah. No, it's
Anuja,
definitely not age. Now I'm older, 1 year older, but now I feel absolutely fine.
Anuja gives me feedback regarding you.
Okay. Okay. She's I really like her. She's very good.
I feel proud to.
Yeah, I really hope she stays on. That's what I was telling our trustees also.
No. I think she will come back to Cuttack. Not
Yeah.
now.
I just hope she stays. Makes my life so much easier.
She is good. Yeah, I am now tensed. She is not there. I have to work like double or triple. When can we start?
Okay, we'll start at 7 o'clock now.
No,
We'll start now.
Vijay, can we start? Vijay Kumar,
Can start. Okay, doctor. Sure.
can
Okay,
you
we can
go
start
live
that.
or we have some time?
Any response from the OT side?
Yes, you can start. You can start, doctor.
Okay.
Just preparation going on, doctor.
Okay.
Thank you. Please, thank you.
So good evening
discuss.
to one and all.
No. They'll give you countdown, sir.
Okay.
Can anybody give countdown, because it should be live at the same time?
It's already live, Santosh. It's streaming. You can.
Yeah, it is already
Live, you can start.
Okay,
Okay.
thank you. Thank you. Good evening, everyone. I welcome you all to this Phaco forum, which is supported by the Apaswamy Associates, and it is a live surgical demonstration and interactive discussion of techniques and technologies. This live surgery is performed under Odisha State Ophthalmological Society. And with me, the co-chairman, Dr. Sudeep Das, the surgeon, Dr. Anurag Mishra, and moderator is Dr. Mohan Rajan, convener is Dr. Madhur Udayaraju, and the number of panelists. The panelists are Dr. Professor Subudhi, Dr. Sabhyasji Patnaik, Dr. Sarmishta Behra, Dr. Shiprasad Sahu, Dr. Devi Aishwarya, Dr. Ashok Kumar Nanda, Dr. Santosh Mahapatra, Dr. Praveen Subudhi, and Dr. Arun Panigrahi. You know, everyone knows about the technique and technology master in Odisha. But today we are fortunate that we have two more technique and technology masters outside the Odisha who is going to stay with us in this evening. One of them is the Professor Mohan Rajan. He's a good friend of mine, and I know him. He's as a punch master and a chopper expert. He is the specialist of the entire globe, anterior and posterior segments. He's a very good innovator, and he has so many awards, 60 awards to his name, and he's a mentor of 500 ophthalmologists, and he had so many accolades and awards in his name. So to name them, it will take some time. So he is one of us today. He has not joined, but he will join us after some time. Coming to next to the Dr. Madhu Udayaraju. He is the specialist of cornea. To his credit, he has done 1,500 keratoplasties, and is mentor of 10 full-time keratologists, cornea surgeons, and 6 part-time cornea surgeons. And he is the first time to having the movements and this keratoconus management. He has done a tremendous work and invented a handheld slit lamp for the evaluation of the cadaveric dead eye. Is another great innovator. So with this, I hand over the mic to the moderator or the convener to carry the meeting. Over to you. Is the moderator not there? Can the convener, can you take the meeting, or Dr. Sarmishta, you can take
Dr. Sudeep Das as a moderator.
Pardon?
Dr. Sudeep Das can take over, I think.
Okay.
Yes, sir. Yes.
Dr. Sudeep
Yeah.
can take over, please.
I think the thing is, I really have no idea what's happening on the side, on the OT side.
And nobody knows that. That is a surprise. But we are hopeful that some interesting technique and technology will come out for a surprise.
So if we can at least have some outline of what is going to happen from there, that will be useful. I mean, not the detailed thing which will happen as it unfolds, but at least a sort of outline of what we are going to see or
If
discuss
Anurag
on.
can, if he is in a position to discuss that.
Yeah, just at least an
thank
outline
you.
of what's going to happen.
Certainly, sir. Thank you so much. Good evening, ladies and gentlemen, wherever you are. Greetings and regards from the land of Jagannath. So we have 6 surgeries lined up for today. Nothing that's out of the blue. That's nothing that's you've not seen before. So out of these 6 surgeries, there would be 2 hydrophobic toric implants. There would be 1 multifocal implant. There would be 1 in focus, which is the EDOF platform coming in from Apaswamy Associates. And there would be a couple of monofocal implants as well. So coming to the technique first, coming to the technology first, I'll just give you an outline of what we are using for those surgeries here tonight. The Phaco machine that will be used for all the procedures would be the Galaxy Pro Orbit, which is also from the House of Apasami Associates. We'll exploit the machine's capabilities as we move on. We'll discuss about it a lot more. It's a nice, tiny tabletop machine, which also comes in with a stand fitted if you wish. Certain things are manual, certain things are very automated. I love the work experience. I think Dr. Sudeep would agree with me. He has also had a taste of this machine, and we know how good it is. Coming in the mid segment, not really low, not really high, somewhere in the mid segment, and it really helps the surgeons across the country. Apart from that, the viewing system we are using today is the Luxor Revalia microscope, surgical microscope coming in from the House of Alcon Laboratories. And if you wish to know anything else, then I would certainly be happy to share that information with you, Dr. Sudeep. As we move on to case number 1, share screen. I'll just show you the details of case number 1. Okay. So this is case number 1, which is a 57 years old female, and she has a nuclear sclerosis of grade 2 with PSCC. The best corrected visual acuity was recorded to be 636, and what we have planned is left eye Phaco with hydrophobic asterisk Toric IOL. This is the IOL Master 700 finding. Go down. So the left eye, as you can see, has a delta of 0.86, so it would be a T3. The requirement would be somewhere around T3. This is the variant planning. Since it's the left eye, we are taking up 20 degrees as the incision plane, and 2.8 millimeters is going to be the size of the incision, because the IOL that we have planned for this patient has got the cartridge size, the peak of which is around 2.8. So that's according to which we have outlined the section. Next, this is the eye trace finding. The eye trace shows that everything's fine. Angle alpha was more, but we were not selecting a multi or a trifocal for this patient, so angle alpha does not count. But as you can see, the trace diffraction also suggests that there is a 3.25 cylinder. These sort of readings always come when you have a posterior subcapsular cataract, which actually hinders the passage of the light that comes in from the ray tracing. Next, this is the specular reading.
Hello, Anurag.
You can see that the hexagonal cell percentage is not. Yes, sir.
Hello.
Yes, sir. Yes,
Sorry,
sir.
sorry to interrupt you. It's
yes,
nice to see you all. I'll be I have joined here now. I'm in a Times Award function, so I'll
Right,
be
sir.
watching.
Welcome.
Yeah, well,
Welcome.
thank you very much. I'm looking forward to seeing your surgery, and I'll be probably joining you from online from 8 o'clock onwards. Thank you very much. All the best.
Thank you, sir.
Thank you.
So coming back, this is a specular picture which shows the hexagonal cell percentage to be 44%, not very high, but not very low as well. Moving on to the next, this is the ASOCT picture. As expected, the lens thickness is not very high again, so it's a grade 2 nuclear sclerosis. And finally, we come to the OCT picture, which shows that the mac is fine without. It's not a diabetic. Also stop share. So with that, we go straight away to the surgery. Anything else, Dr. Sudeep, you wish to know regarding the case?
No, that's fine. Everything seems to be fine.
So the planning has registered. So we are about to start.
So this is the Apasami one you're using, or which one? The digital intraoperative?
No, this is the variant, sir.
Okay.
The Apasami one comes integrated with the microscope, if I'm not wrong. And it actually has a different screen altogether. I don't think it has
it has a different
overlay
screen.
on the Mac.
You can't
it doesn't
see it
have an overlay on
through
the
the Oculus.
Right. Siddhartha Kondama. Off. The first thing that struck me when I started using the machine was the weight of the handpiece. It is extremely light, measuring in hardly 35 grams is what they say officially. I obviously couldn't gauge the weight of it, but it was very light. Sleek, feels light on hand, and I also love the grip that they have given.
It's actually the lightest handpiece I ever used, and it's very slim.
Absolutely,
also. It's very
sleek,
slim.
very sleek.
Yeah.
And the interesting thing about the other interesting feature about the handpiece is that it has got 6 crystals. So it's not that it's light on there. So it has got 6 crystals, yet it's very light.
Yeah.
So the days when we recount the days of, I think the good old legacy, which had the Neosonics handpiece, and it just felt like a dumb. Coming from there, we have actually come of age to as regards to the weight of the handpieces that we use nowadays.
Well, if you talk about Dr. Kelman, he used something with a cantilever system to support the handpiece. It was so heavy.
Really?
Yes.
So softish cataracts are to be chopped with a little bit of caution, because we know that they can cheese wire. So the hold of the machine has to be good. It has to support you.
Actually, what I find most amazing about the Orbit machine is the anterior chamber stability. It's amazingly
Absolutely.
good. It's just
I also
absolutely
told
rock
them,
steady.
Absolutely. So what they have really come up in their support as far as pitching regarding the machine is concerned is the dynamics, but it is actually the fluidics which should receive the emphasis, because the fluidics is extraordinarily good, very good. And one of the best when you come to a gravity-dependent machine of available in this segment.
Yeah.
Talking about the price point of the gadget.
Actually, so, it's comparable to a lot of things which are even double the cost of this.
Correct.
Which still come in the mid segment, but it's way better than those.
Dr. Madhu, we are waiting to hear from you.
Sir, I think I just wanted to know the parameters that you are using for the interest.
Yes, I was just about to. Yeah, I was just about to come to that.
Yeah.
So the vacuum is 350.
Okay, sir.
The vacuum is 350, and the power is 50. I'm in the quad mode right now, which gives me a power of 50.
And the AFR is what, about 35?
Yes, 34, I think.
Okay. And what is the Phaco delivery, sir? Pulse or O-pulse?
It is a continuous and O-pulse.
Continuous.
So it is continuous, and then there's a pulse mode that is just for the benefit of the audience who do not know what O-pulse is. Yeah. It is occlusion pulse. So post occlusion, it changes into the pulse mode, and before occlusion, it is continuous.
Okay. Okay. Yeah. I think I too prefer to use the same setting, sir. but I'm more of a venturi surgeon. So excellent. I think the anterior chamber was very stable throughout the surgery.
It is.
Especially when you can make out when you remove the last piece. One thing is you're seeing everything a lot clearer because the view is good. And there's not even a flicker at that stage when the last piece went in.
True, sir, true. So this is a coaxial thing you are using, sir?
I always use a coaxial. I'm a big admirer of coaxial system of IA. So I don't normally use a bimanual unless and until it is called for that particular case. I mean, if it's a polar cataract or otherwise, if I have had a PCR, I'm forced to use one. Otherwise, the coaxial is my favored IA cannula that I use as a staple technique in my procedures.
Yes, yes.
Good evening to the other panelists. I don't know who all have joined and why are they muted.
What lens are you planning to implant, sir, in this case?
This is the Supra-Phobe Toric, the premium hydrophobic aspheric Toric IOL coming in from Appasamy.
Okay.
So the implantation axis is 165.
So you'll be taking advantage of the luxury overlay in this.
Yes, the variant overlay of this.
So otherwise, do you prefer to mark it over the slit lamp, sir?
No, I actually have completely given up manual marking nowadays since variant has come in.
What do you suggest for surgeons who can't go for variant?
Manual marking, obviously, but out of the techniques that I have used over the years of manual marking, I think the best is the slit lamp scratch, superficial epithelial scratch, because that stays for a long time. And the moment you take the patient to the OT, if you just add in a drop of trypan blue, then it stays on. It stays on for a long, long time. So neither is it too visible, nor is it too blotchy. So it's a tiny, thin ring, and it really stays for the whole business duration, or as long as you wish it or you desire it.
Yes, sir.
Admin, can you check from where we have an echo?
What is your experience with the rotational stability, sir, of these lenses?
To be perfectly honest with you, I don't have a massive experience with these. They perform very well as far as refraction stability is concerned post-op. I mean, I'm talking about this platform, but as far as toricity is concerned, they should be good, because I implant a lot of RILs coming in from Appasamy, and they of course are of a different material altogether, and the design is also
and it's
radically
RIL is also a smart toric, no, sir? You just need to place it 0-180.
No, RIL is a
not
phakic
always.
lens. It's a phakic.
It's a phakic IOL. It's
phakic IOL.
Not always.
It is like
not
you
always
place it
are
at
they
0-180. Correct.
Yeah,
place it at
0-180
always.
Yeah, most of the time, yes, that is correct. But sometimes they have an additional toric mark, which is very close to 0-180, but not exactly along 0 and 180.
Okay.
So if you don't have a toric mark on the surface of the optic in RIL, then you have to place it along 0 and 180. But Alama, thank you. But if not,
I have
then
used
there's
quite a few of these toric lenses, and I think they are pretty rotationally quite stable. I really haven't seen them move around.
Dr. Anurag.
Yes, sir.
I have a question for you. You are using coaxial irrigation, aspiration irrigation. Then why you made 3 ports?
Yeah, that's
ports?
an interesting question. The other side port was actually used to align the toric IOL, sir. If you've noticed it, the other side port is used to align the toric IOL. And even if I'm not implanting a toric IOL, I still go ahead and construct the other side port, because the other side port is at times required to remove the subincisional cortex, which is sometimes difficult to remove with the
Acha,
coaxial. I
preventive
know
measure.
it
Okay.
happens. Yeah, it happens rarely, but still, I just have another entry made so that it's life becomes easy for me if I need the services of the same.
Okay.
So when
Thank
do
you.
you prefer to see the post-op of this case, sir, especially in toric IOLs? Do you see it on the same day or next day?
Yeah, so many people follow the strategy of seeing the patient for the first hour because it has been believed that more than 90% of the post-op rotation occurs in the first hour of implant.
Exactly.
But I don't do that. I don't do that because I trust the IOLs, the IOLs that I use, they have a very good track record. So I don't do that. So my protocol is to call the patient back after 15 days and I maintain that even in toric implants, unless and until the patient complains of something. If Dr. Sudeep Das's statements, and we know that he's a prolific surgeon, so if it is to be believed, so if these lenses also behave the same as far as rotational stability is concerned, so I think we can also leave a gap between the surgery and the post-op. Don't need to see them the very next day and gauge the rotational stability.
Yeah, I just wanted to highlight the discussion that most of the surgeons still prefer to see it 1 hour post-op, as you have highlighted that the stability is seen mostly, or any dislocations can happen during this critical time. Yeah, thank you, sir. Thank you for the
Actually, it's not in the first 1 hour. My belief is that we see these IOLs which are misaligned and they are actually on the table. We haven't aligned them correctly, because what I had done for quite a number of cases when I was in Bangalore is I used to get my, and these are all topical surgeries. So I used to get one of my fellows who was in the OT to see them immediately after implantation on the slit lamp and check. And then some of them were off and not enough to sort of need a redialing.
Yeah.
Some of them would, and we saw them the next day and it would be exactly the same. So my feeling is that we just, because of the parallax and various other things, we don't actually align it properly and we blame it on the IOL rotating. Sometimes it does occur because you'll see it some, like there was one person in which I saw the IOL was aligned okay sort of on the first day, and then after some weeks when he came back, it was totally misaligned. And I redialed it the same day, it went back exactly to the same. So there's something wrong with that, probably the shape of the bag. There, because it was rotating exactly back to the same angle. So that's different. But otherwise, I think it's just a misalignment on the table itself.
Yeah, that's a very practical point. Yeah, thank you, sir.
Yeah, and these are like do the surgery, see the next minute on the slit lamp outside the OT. I had a slit lamp just outside the OT.
Yeah, we too also have the same setup, sir, where we prefer to see immediately.
Yeah.
And if you have such a massive rotation of the IOL, then perhaps it would be not a bad idea to actually go in for a reverse optic capture in these lenses. So align them along the axis. And if you're not sure about the behavior of the capsular bag post-operatively, then you can reverse capture the optic, and that just adds to the stability. So any word from Praveen, Arun, are they there in the panel, Devi ma'am, or should we go on to the next case?
Just wanted to ask one question, sir.
Sorry, I didn't hear that.
Hello, can you hear me, sir?
Arun,
we can hear you.
Yeah, we can hear you.
Is there anything to do with the size of the capsular axis with rotation or anything?
I'll let Dr. Sudeep answer that.
No, I don't think so. I mean, I prefer not the immediate rotation. Later on, yes, it can have very different results if you have made a large capsular axis, and then the IOL actually tends to go in front of that, and then it contracts, especially if it's an unequal, like it's not centered, then you can have problems because IOL can migrate in one or the other direction. But otherwise, I don't think it has really much of an effect because the haptics are going to be somewhere near the equator. So it's really, I don't think that matters.
Yeah, just to add to that, what happens here is if you don't have a perfect shrink wrap, if you don't have a perfect shrink wrap effect of the capsular axis all around the optic, then with time, if there is a ring of sommering formation in the parts that are covering the optic and in the part that is not covering the optic, so the IOL might just go for a micro tilt. So that micro tilt actually contributes to the post-operative astigmatic drift and not the rotation. We often take it to be the rotation of the IOL, which is not the case.
Even if it shifts
Right,
to
so
one
this-
side, even
Yes.
if it shifts to one side, towards a side with, more, there can actually be a prismatic effect of the lens, which can also create problems.
Absolutely, because it's a
Because the
biconvex,
center is no
biconvex
longer
or
aligned with
planoconvex.
the visual axis.
So this is case number 2, ladies and gentlemen, which is a 63 years old male, and the nuclear sclerosis in this case is grade 2 or 3. The BCVA was 636, and what we have planned is for the right eye, we have planned a Phaco with hydrophobic asterisk, multifocal IOL, which is also from the house of Apasami Associates. We'll talk about the IOL a little later. So the 700 shows us that the delta is perfectly acceptable. 0.12. Go on to the next. The variant planning is 2.8, but since this is the right eye, we can plan it along the 0 or 180, as the case may be. Go on to the next one, please. This is the eye trace. The angle alpha is perfectly suitable to receive a multifocal IOL. Just to tell you that the central bullseye of this IOL is 1.8. So we have a tolerance till 0.8 as far as angle alpha is concerned. But this is way below that. And you can see that the astigmatism is not much, neither on the corneal plane nor on the internal plane. Go on to the next one, please. This is the specular microscopy picture. The hexagonal cell percentage is doing good. So does the cell density. This is the ASOCT. The lens thickness is quite high, but it's okay. I mean, the ACD is good, so we have a good business area to work with. And this is the OCT picture, which also shows structure, which also shows that there is nothing in the posterior floor to be concerned about. Wherein the see that on the light, please. So the whole synopsis comes on top, and when we implant the next Toric IOL, we will discuss about how, even if you are using a markerless system, that does not necessarily free you from your responsibility of Siddhartha on the light go again, Ekdam Siddhartha. That doesn't free you from the responsibility of knowing where you are leaving the IOL, because there are tricks to know which is the perfect position in which you Siddhartha on the light go. The perfect position in which you align the IOL. So how to know that is something we'll discuss when we do the next toric. We have another toric implant, the 2.8 millimeter section and the first side port. See that the contact light go. The red glow that you get with the Luxor Rivalia is absolutely brilliant. I mean, wherever you move the eye, it just doesn't leave you. It just doesn't go off. Where's Praveen? Praveen, are you there? See that on the light go. See that on the light go. See that on the light go. So we're going with the three same parameters. 350 is the vacuum, 50 is the Phaco par, linear, and around 35 is the flow rate for the chop mode. The flow rates improve slightly to 37 in the quad mode, and the power remains the same. It's only the delivery that changes to O pulse along with continuous, with the power amplitude remaining the same at 50.
What is the chopper you are using, sir?
I'm using the Chang's chopper
It's a
coming in
blunted
from
one?
Epsilon. No, it's a sharp one.
Okay.
And I use the same chopper for every grade of cataract. Doesn't change. I mean, even if it's soft cataract, it stays on.
Okay. Okay.
I don't have a blunt chopper. I don't normally, not very fond of it. Because I actually, when there's a soft cataract, I prefer to do a mechanical or a vacuum chop. And a blunt chopper, a sharp chopper to me does a better job than the blunt choppers when you have a soft cataract and you want to do it mechanically without using any power.
Right, sir. Right.
I think we have already seen examples to know the followability that this machine offers us, haven't we?
Yes.
It removes the cataract so fast. And the only thing that I would honestly confess before all of you, I did try to be over enthusiastic at one given point in time and used a vacuum which was much more than the recommended 400. You can scale it up because the scale is there, but that is not recommended. So, and you don't need a vacuum which is beyond 350, 370 for most of your surgeries. I think you can jolly well see that happening.
Excellent, sir. Excellent.
I'm
How is the chamber stability, sir? It looks good in
absolutely
the video.
great. Absolutely great. So as you can see, perhaps it is
Yeah,
done.
it looks
As
good.
Dr. Sudeep,
Yeah, it looks great in the
it looks
video.
really good.
But from the surgeon's experience, that I wanted to get.
So when you have reusable tubing systems operating in the Phaco machines, and they're not really closed circuits, so we do have the issue of a gush of air bubbles entering the eye at times. That also is something surprisingly I don't find with this particular machine. I don't find air bubbles coming in that frequently. So, I mean, it's not something that is hugely important or impact creating, but it is when it comes to the surgeon's agony on the OT table when you have a long list to finish and suddenly you find a gush of air bubbles and you have those extra seconds invested to clear them out before you go ahead and do the next step. It sometimes becomes agonizing. So I've not seen that happening with this machine very frequently. In fact, not at all. So brilliant. So we go to the, as I was saying, that the central bullseye is 1.8 in this case. So this gives us a very good clearance with regards to angle alpha. The tolerance would be around 0.8, 0.85. And you hardly would get a patient who has got an angle alpha more than that, 0.8, 0.85. So everybody would be well within that range. And it's a refractive-diffractive design. As you can see, the haptics are so-called muscle haptics, which are beaded. So that also offers an additional stability to the peripheral portions of the IOL against the equator. There are 24 rings. It's a full optic diffractive design. So relatively pupil independent. So even if the mesopic conditions dilate the pupil considerably, there should not be any effect on the multifocality impacted. The light transmission is also good. So that should also be well within the tolerable limit.
Can you zoom in a little bit, sir, to appreciate the rings?
Certainly. Microscope put this other Okay, now can you see?
Yeah, better, sir. Better. Yeah. Thank you.
And you can also see the Purkinje images very clearly from here.
Yeah.
The one that on the top is actually for the stereocoaxial illumination, so that is not to be counted. But the two main images that are for the oblique illumination are falling right at the center of the central bullseye, which is the reason, which is in fact the reason why you should always look at the angle alpha before deciding on a multifocal implant. So they're doing fine in this particular case. And that's exactly where you should wish to see them. So that's the end of the case. Case number 2. Any inputs?
Excellent, sir. You made it look so effortless.
Thank you. Any other opinion coming from any other panelists, or should we move on to the next case? I don't know how many of them are there on the board, though. Sudeep, sir?
Yeah, what I was saying is I can imagine why you're not using the Rexis marker. You don't need it at all. It's perfectly centered and circular.
Yes, I think Varian has done its job coaching me. So I have been a complete finished product now, so I don't need its coaching anymore.
No, actually, I used to find it, I mean, I didn't use it long enough, but I used to always find it very irritating because it sort of comes in the way of what you're doing.
Yeah, at times, actually, even today, when I compare the non-Varian overlay Rexis with the Varian overlay Rexis, they look geometrically fine. But at times, when you center them around limbus, since Varian calculates where the limbus is and where the center of the capsular bag presumably would be. So even if it looks off axis initially, when you actually finish off implanting the IOL, you will see that it's perfectly centered. So that way, in some cases, it might just have its impact, but otherwise, without the help of that, also you can do a fair bit of job.
Yeah.
So this is case number 3, youngish male, 44 years old male, and the cataracts hardly any. There's only a grade 1 nuclear sclerosis with a few cortical opacities. The other eye was operated sometime back and was given an in-focus. The patient's very happy with the in-focus implant in that eye. So that's exactly what we have planned for this eye as well. It's a habitual nighttime driver, so the other eye cataract also had to be removed fast. The BCVA is 612, and what we have planned is the left eye in focus. So the delta is 0.41 in this case. Once again, pretty much in the acceptable range. The Varian planning suggests a 2.8 millimeter section placed at 20. The ITRIS suggests that the angle alpha is slightly more, 0.6, so perhaps not very, very suitable when it comes to multifocal implants, but EDOF can have long tolerance ranges. So you can go ahead and put EDOF lenses, even if the angle alpha is more. I mean, up till 1, I have implanted EDOFs with pretty good results. This is the specular reading. The hexagonal cell is 48, close to 50, doing pretty well there. The ASOCT shows that the lens thickness is not very high, and you can see that the echo is not exactly looking right. So not much of a cataract in there, more of cortical opacity, as is shown by the ASOCT. And we haven't, the ASOCT, the OCT picture was not taken by the machine somehow, probably because the cortical opacities were creating a lot of disturbance in the media. So the picture is not taken properly. And this is the patient's eye.
Actually, you've been using all these IOLs need a 2.8, but I've used a 2.2 on the Orbit, and even the 2.2 is so phenomenally stable.
Siddharth, on the light. Change it over to 2.2, please. We'll use a 2.2 for at least one case. 2.2 tip and sleeve, please. 2.2 blade, please. I totally agree with you, Sudipta, and that's exactly what we are going to do in this case.
Yeah.
We are going to switch over to 2.2. And so unlike some of the other machines, I mean, some of the machines do not change the tip when you move from 2.8 to 2.2. Some of the machines do. This is one of those machines which does change the tip when you change the platform. So it goes into the 21 gauge tip from a 20 gauge tip when you move from 2.8 to 2.2. But as Sudeep sir was suggesting, the chamber stability remains rock steady. And in fact, the chamber stability remains steady since the aspiration is brought down. The speed at which things have sucked out of the AC is brought down. Theoretically, that is the case of. But what is important is the way they have designed the sleeve, because the sleeve also changes, and it's a high flow sleeve. So the fluid that enters does not change; it remains the same. And at times with a 2.2 millimeter, I mean a 21 gauge tip, you have to do some customization in the vacuum area because it does not have the same effect as it does with a wider tip. But not in this machine. I've not found that playing a role in this machine at all, because the
No, absolutely not. It holds well. And you were saying that some of them don't actually change. Many of them actually don't change the tip, but then they change the sleeve. But then the problem is, if you're using a narrower tip with a wider sleeve, you'll find actually fluid comes out through the front from the tip. So you have 3 jets of
True.
fluid, which is not an ideal situation. It doesn't happen in this.
Incision in this case, you have made 2.8, sir?
2.8, 2.2. This incision is 2.2.
2.2.
We'll extend it later on because the cartridge does not go through 2.2. So we'll expand it later, but right now it is 2.2.
2.2. Okay, sir. Okay.
Just trying to carousel the peripheral portion of the soft nucleus because this doesn't need any power to be consumed. So we're just aspirating the peripheral portion and carouseling the peripheral portion so that we have a single bowl of nucleus right at the center, which would not be very hard and would not be very difficult for us to take out. And we are not using any power in this case, just aspirating it. And look at the way even that small bore tip is holding the anterior chamber together steadily, and at the same time, just aspirating the soft nucleus.
Vacuum is at 350, sir? Same setting.
Yes, it's the same setting.
And this is with a 2.2 tip. Amazing.
This is for, yes. So the epinucleus saucer will be flipped now, yes, and then it will be consumed. You're done.
Wonderful. Again, perfectly stable anterior chamber, even at the end.
They also have the liberty of different bevel planes, bevel angles. The one I'm using is a 15-degree bevel. You can also choose a 30 or a 45 if you are more comfortable with that. I just used the one they gave me, not really tried the other two. But they have that that bevel angle available with all the platforms, both with 2.2 and 2.8. That also is amazing. So many choices.
And they have
available.
straight tips and angle tips.
Yes, that too. Yes, the straight and the Kelman.
It's actually not a Kelman because it's better than a Kelman because it's not narrowed at the neck. So it doesn't clog as much as a Kelman tip.
Achha. Okay, so that one I didn't know. It still bears an angle of 23 degrees is what was told to me. So I thought it would be.
Yeah, no, but it's not a sort of, it's not a expanded tip. So it doesn't sort of bite more than it can swallow.
So this is the InFocus IOL. You can see the refractive zone right at the center, which is dedicated for near and intermediate, the diameter of which is 1.4. It also has muscle haptics, so the stability is good. I think it's very clearly visible. Should I zoom in for you, sir, for you to appreciate that more clearly?
No, it's quite visible, sir. Thank you.
The patient was so happy in the other eye with the InFocus implant that he just came in and requested the same implant to go in. So we kept his request. Of course, I mean, if it's not people dependent by and large, but if you have a decentration of the IOL, as I found in one of the patients that came to me recently, everything changes, because if you have the circle bisecting the pupil somehow, then you would have a lot of distortion. The patient would have a lot of distortion. So we're done with case number 3. I think we are moving too fast. We might just finish off before Dr. Mohan Rajan even joins. Thank you.
He's got a Times Award, so anyway, it may not be possible.
Yeah, so he said he would be very keen to join, and the time would be around 8 p.m. That's around 7 to 8 minutes. But we still don't have anything from the other panelists. Why are they silent? Who all are there? Arun did speak a few words sometime back. Who are the others?
Hi, Anurag.
Hello, ma'am. Good evening.
Yeah, I'm sorry I was a bit late. I had another class that I had to attend. So missed.
Oh, you just joined?
Yeah, just now.
All right.
I think all the panelists are spellbound by your magic.
No, that's not the case, sir. I'm sure they must be busy with something else. I'm sure he must be sipping it. If it's not there, he must be evening coffee.
One hypothetical question. So, suppose you are having some surprise element during the surgery, like hello, is it audible, sir?
Yes,
yeah, Arun, we can hear you.
If there is a surprise element during surgery, if you come across some amount of general dialysis or something like that, would you still go ahead with the surgery and the planned IOL, multifocal, or this thing, or you have to change, or it depends on the amount of general dialysis?
Go ahead and implant a CTR first. It's really fine to me. I'll go ahead and implant a CTR first. And tweaked at one plane. If it's not perfectly circular, if it is collapsing from one end, I'll definitely give it a serious thought. Perhaps I would change my plans, go ahead and implant a monofocal and explain the patient accordingly. But if the back size is good, if the back shape is good, and the rexus is appearing perfectly circular the way I made it at the first go, then I would not mind implanting a multi or a tri or even a toric. All that if the dialysis is less than say 4 clock hours. If it's beyond that, then I would probably not go ahead and do it, because I have seen people burning their fingers and I've seen post-ops. Initially, they might look all right to the eyes, but as time progresses, particularly in cases wherein you're likely to have a big group of zonules, it does have future effects. So probably not.
Mostly in cases of
Don't,
multifocal.
sorry?
Mostly in cases of multifocals, like even if the bag is good, if it is not centered well, then the patient will end up in problem and it will create nuisances post-op.
So since you cannot see the equator, what you can see is the rexus margin.
Yes.
If it's not eccentric, and if it's maintaining the shape you made it along the initial few seconds, then probably it's a good idea to go ahead and put it. Otherwise, not.
Okay.
Actually, if there is a patient with generalized zonular weakness due to a progressive zonulopathy, then I would think that it's not a good idea to implant, because they will have capsular phimosis even with CTRs and all, and you really cannot predict how the rexus is going to migrate. So those are cases like gross pseudoexfoliation, or doesn't really make sense implanting those lenses.
In some cases, sometimes the tilt also will make some problems later on, I think.
True. They will make a lot of problems, Arun. You are when you are putting in a multifocal or a trifocal, you're already reducing the patient's contrast. You're already inducing some amount of distortion of the image. Let's face it, it's the truth. So if the lens filters, there is more distortion that is added on. And that distortion is very close to the nodal point. So the patient is going to be extremely unhappy. You add coma. So the patient is going to be extremely unhappy. So this is case number 4, which is a 57 years female. The grade of the nuclear sclerosis is around 3. The BCVA was 624 partial, and we plan for the right eye a Phaco with hydrophobic aspheric semi-preloaded Toric IOL, so which is in the platform of Superfo, which is a semi-preloaded platform from Apasami Associates. Go on to the next one. This is the 700 reading. The delta in this case is 0.85. A T4 implant, I think, would be suitable. The variant shows that its implantation axis is along. Okay, we'll see that later. It's very tiny in the front. The next one to the next one, please. The eye trace shows that there's no internal astigmatism. The astigmatism, the total eye astigmatism is contributed by this. Next. This is the specular reading. The hexagonal cell is 39%, a bit on the lower side, but the CD count is doing fine on the central zone. The ASOCT shows that the nuclear sclerosis is pretty good. It's a strong, dense nuclear sclerosis. The ACD is a little on the lower side, but it should do fine. And then we have the OCT, which shows that the posterior pole is also doing pretty okay. In this case, we also did the dry eye suite, which I've forgotten to add in these slides. Stop share, please. That also was done, and it was found to be perfectly fine. The dry eye suite was also taken up for the previous patient who was given the in focus as the implant. That also the surface was doing fine.
So which dry eye diagnosis do you use, sir, routinely?
The IDRA, the EI and the IDRA.
Okay, so you look for the tear film, this thing, stability. And
it actually gives us a comprehensive reading of all the aspects. It gives us the MGD, it gives us the mimography, it gives us the T-butt. So it gives us everything in one printout of both eyes together.
So if you have a
I'm sorry, sir, I didn't get that.
Yeah, so if you have a compromised ocular surface, would you prefer optimizing it first before going to refractive outcomes?
Very true. Absolutely, because all our supposed ATIL patients who are even looking like they would opt for an ATIL, even torics, mandatorily undergo the dry eye suit mandatorily undergo the dry eye suit evaluation before anything. We, apart from the ALMaster 700, we also have the Anterion, the Heidelberg's Anterion, as you saw. The ASOCity pictures are coming from there. So that also does biometry, and it gives us a clue as to whether or not the ocular surface is looking good. So it doesn't measure the ocular surface, but it gives us a message whether it is good or it is borderlinely defective. So if the surface is not looking good to the machine, it gives us a clue. So from there, we know that the patient needs to be subjected to a dry eye suite.
Yes, sir.
But we are very happy with the way these two machines perform actually in evaluating dry eye or even treating them with IRPL if a patient needs it.
So for IRPL, you're using
we're using the EI. Yes.
EI, okay.
Yes, the accomplice of the eye draft. So both of them come from My Healthscape, and
yes, sir. I am also using the same platforms.
Yeah. So I, before buying the machine, before getting it installed, I actually used the EI to treat my own dry eyes, and I found it extremely comfortable. I stayed very happy for the next 4 weeks or so. And then I repeated the treatment and was even happier than I was before. So I thought this is the right kind of machine for me. Since it is making me happy as a patient, it should make my patients happy as well.
True.
See that on the map? सीधा देखो तो लाइट को
Anurag sir, can you repeat the parameters, please? 1 second. For this cataract.
So I'm using a 50 power amplitude of 50, Phaco power of 50, linear. The aspiration flow rate is 35. The vacuum 350.
Okay. So you keep everything same, or you have to change according to the grade of cataract?
I normally don't. If it's a very hard cataract, I'll just go up maybe in the power segment. From 50, I'll scale it up to 60, but keep the linear thing on. Normally don't like to use a non-linear mode of power delivery because I think it's a wastage of power. So it's better that you have the control in your foot switch and use just the quantity of Phaco energy that you require.
I agree with that. The other thing people are not familiar, this is sort of a combination of longitudinal and torsional. The power delivery in this.
Yes. So there is a reason why it's called the orbit. because it orbitates the phaco tip. So along with longitudinal, you also have a bit of rotational movement of the tip. So that just augments the performance.
The other thing
But
that
see, this
I
is,
have found,
yeah,
and you can see in the video, is that there is very little chatter in this.
yes. And this being a fairly leathery cataract, not a very hard cataract though, but it's not a very soft cataract as well. And you just saw from the ASOCT picture that the nucleus is pretty thick.
I think that was the reason the anterior chamber depth was less. I don't know what the lens thickness
yes.
was, but it looked like the lens thickness was very high.
Yes.
And that is the
Yes,
reason
yes.
the anterior chamber was slightly shallow.
But despite of that, you can see that the business area is quite profound. I mean, we can maneuver things easily because the fluidics of the machine actually keep the anterior chamber bloated and to our comfort.
Actually, I was using this machine a few days back, and I was actually enjoying using this. I was getting a kick out of using this. And then the other doctors also, they have also really started to enjoy using this machine. When you don't have to bother about the PC coming forward, half your job, more than half your job is done.
Very true. Very true. That's perfect. Just to give you a count of the energy that we used in this particular case, the ultrasonic time is 1 minute and 58 seconds. Have you reset it? Yeah. So it's 1 minute and 58 seconds. A little on the higher side still, because this was slightly on the harder side, the nuclear sclerosis, but it still is perfectly reasonable. I mean,
sir, in these cases, probably after you chop, we can also change the mode to impulse to reduce the phaco energy, sir.
The micropulse?
Yes, sir.
Okay.
For me, it depends on personal preference, I think. For me, it wasn't, I didn't like that very much.
It's slower, sir.
I was just going to say that. I was about to say that.
I like the occlusion pulse, but not the occlusion micropulse. That wasn't somehow very, not a very happy thing for me.
Yeah, actually, it takes a bit longer time, sir, but the energy drastically come down, sir, in my experience.
Yeah, but that is not the whole idea. I mean, energy anyway,
Yeah,
it's not going
it
to do
has to
anything to
be.
the cornea.
I just showed you the specular picture for the same reason, sir. The hexagonal cell percentage is slightly on the lower side.
Okay.
So it's okay that we are not using too much of power, but we are also bathing the anterior chamber with fluid if we are staying there for longer. So that also can cause micro trauma to the endothelium. So it's a good idea to finish off the job fast and come out. So, but as Sudeep sir rightly suggested, it's a personal thing. It's a personal preference, what we would like to use. Dr. Aishwarya, if you're still there with us, we would like to hear from you. Angle, axis. So I always inquire about the axis of implant before I go ahead and push in the toric. There's a reason why I do that. I'll just tell you. It's just squeezing the eye like anything. Tap on the name, man. Tap on the name. Tap on the name to go. So unlike many of the other IOLs, which give you a dotted imprint on the IOL surface, this has a straight line. They maintain the same pattern even on RIL. So this is what I mentioned. If you look at the ball that is in this hyperbola here on variant, the ball has to be visible to you when you align the IOL. And if you see this message out here, tracking okay. The tracking should be okay, and the ball has to be visible to you when you align and leave the IOL in that place. Because if you don't see these two things and you align the IOL to your satisfaction and leave it like that, it might not be properly aligned. It might be a 5 or 7 or 10 degrees off axis implantation. So we're just trying to say that even if you have a markerless system, it doesn't really take away all of your responsibilities. You have to have a few cross-check points to ensure that even if you have the markerless system, you're leaving the IOL just at the plane that you desire. Most of my patients, I don't hydrate the main port, particularly if it's a 2.2. Here in with a 2.8 also, you don't require to hydrate the main port, which also suggests that the handpiece is not stretching the wound at all. So the wound is staying free from the potential insult by the handpiece entering in, coming out, and the fluidic. So it is no stromal hydration, as you could see. Despite of the energy being used, since it's fractionated into longitudinal and orbit, maybe it's very soft on the wound. There's no stromal hydration. There's no wound burn. Very soft on the tissues.
Sir, did you have a chance to use the turbo width, sir, upper turbo width?
No, sir. I don't even know what that is.
That's a Venturi machine, sir, from Appasamy.
Okay.
It works both for anterior and posterior segments.
Okay.
And I prefer to use the Venturi machine, and I use it regularly. I think whatever you're doing on this is even much better in that, sir, in my experience.
Oh.
It has a better holdability, especially in hard cataracts. The hold that we get out of Venturi is very nice, sir.
And for the Venturi pump to operate in that machine, do you have to have an external gas source, or is the canister inbuilt?
Yeah, no, sir. Actually, it has they supply it with the compressor. You can also attach it to a gas source.
Okay.
And it's the same tubing that you can use for the posterior segment surgeries also.
Okay, so they're not disposable. They're reusable tubing.
Reusable tubing, sir.
Wonderful. Wonderful. So we all are sure it must be a wonderful machine to work with, Dr. Madhu, because I think everything that has come from that house has been brilliant. I think thousands, tens of thousands of ophthalmologists all across the country, in our country and abroad, they have actually stood their ground. They have been able to stand on their twin feet and do Phacos and surgeries and establish their practices because of Appasamy supporting them in all corners, starting from the ophthalmic chairs to the slit lamps to the biometry machines. They are a wholesome unit. I've been to their factory recently, which was the smaller of the two factories they have in Tamil Nadu, which was at Chennai. And I was, for the first time in my life, I saw mountains of IOLs, and I asked them, how come the production? Because that is the kind of demand they have coming and pouring in from everywhere. But the quality maintenance is very good. I saw the tumbling cleaning techniques, the sterilization techniques of the materials. I also saw the making of the ophthalmic chairs. Pretty amazing. you take one tour of the factory. I was mesmerized, and the hangover stayed with me for a couple of days thereafter. So moving on to case,
Yeah.
Yes. Sorry.
Please go on, sir. Please go ahead with the next case.
Okay, so the next case number 5, is a 53 years old female. The nuclear sclerosis again falls in the range of 2 to 3. The best corrected visual acuity of 624. We're taking up the right eye for surgery in this case, and what we have planned is Phaco with hydrophobic aspheric preloaded IOL, the supra phobe monofocal platform coming in from Apasani. This is a 700 reading. The delta is 0.40. So the patient did not need a toric. The variant planning showed that the patient did not need a toric. So just to tell you that you can customize whether the patient would need a toric or not on variant, and you can keep your threshold as minimum as you wish to. So I have kept it around 0.7, which of course suits me very well because the residual spherical error, the spherical equivalence has to be somewhere around 0.3 is what is acceptable to me. If it goes beyond that, then variant immediately shows me a toric planning for that particular patient. Next is the specular. The hexagonal cell percentage is 51. The CD is good, 2344 in the central zone. And next is the OCT. You can see the nucleus right at the center. It's not very large. The ACD is quite good, but it's a dense nucleus sclerosis, whatever zone it is occupying. Next is the eye trace. Again, the angle alpha is more here, so the patient was counseled to receive a multifocal, which the patient was initially interested for. And though the 1.25 is the tracy diffraction, but it's calculated on the IOL plane. And if you have a cataract this hard, this dense, then it can always take that into account and show you a higher value, which isn't the case. So you can see the astigmatism plane both on the cornea and the internal plane are quite balancing out each other. So the resultant output should be close to 0. And finally, the OCT shows that the posterior pole, next posterior pole is also doing fine. Stop share. And this is the patient.
Anurag, you do all these tests routinely for all cataract surgeries?
Yes, we do all these tests for all patients, even if they come from the BSKY front. Even if they come from the BSKY front, because some of these BSKY patients have given us excellent documentary feeds for my presentations in different forums. So we do everything for every patient. And interestingly, we have, my kids are, all of them are trained in everything. So all of them can handle the OPD, all of them can handle the OT, all of them can assist, all of them can do the running work, all of them can do all the investigations. So everybody is trained in everything. All of them can be counselors too, if such need arises. We're a fantastic team in place. I'm really happy and really thankful for that. And off late, I've also enjoyed the experience I've had with this particular microscope. I'm sorry, I don't know whether I should be saying that and if this is the right kind of forum for that, but I've really enjoyed my days of operating with the Luxor Rivalia, because it gives me such clarity, such good view. Despite of this being webcasted, I think all of you can jolly well make out what clarity does it offer off. सीधा रखो, लाइट को सीधा रखो ना, नहीं 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 सीधा रखो लाइट. We're not changing the parameters. It's going in the same. It has worked for us, so it should work for us even now. So at this end, what I'm feeling is, though I have the O pulse, the occlusion pulse, hardly there is any time when the pulse energy is being operational, because even if the the setting is such that it will operate only when the tip is occluded, and it's not giving the machine an opportunity to occlude. Before that, the piece is being emulsified. It is so fast that I'm not getting to see the pulse mode being operational at all.
That you only see in the very hard cataracts, the really brown cataracts.
Maybe. थोड़ा कलर छोड़ी था इतने अपन तो नहीं कि
After your IA, I see you going in with straight cannula. Is it to blast the PC with fluid to remove the
Yes,
fibers on the
the
PC?
stub-on cortical. Yes, sir.
Okay.
Do that almost in every case, and in
Yeah.
fact, the need for that has increased since I've got the Revalia, because it shows me everything so clearly that you can't.
Yeah.
I mean, you don't feel like leaving them behind. So
You don't
hydro
prefer-
polish is what they call it. Yeah. Sorry.
Sir, you don't prefer to use the intracameral antibiotics, sir?
Yes, sir. This is the one. Right now, I'm pushing it in.
Oh, okay, right.
Intracameral moxifloxacin. That goes in every case.
Every case, yeah.
Every single case.
Yes.
I think that has been proved beyond any point of doubt.
Oh,
now.
absolutely.
After this
Absolutely. It doesn't
big,
make any sense not to use anymore.
there's this massive scale study, all thanks to Arvind,
Yeah.
with the help of Dr. David Chang. I think they have established it beyond any doubt. So you get a better sleep in the night if you're using it.
And nobody else can do with, that large a number of patients, a study with such a huge number of patients.
True. Sudeep sir, I think we have a few hands raised. I can see a few people raising hands. Can the admin unmute them? Do they want to say something?
I think the admin will have to help us because I can't see anything here.
Okay.
Yes, we are in the panelist window. I think admin should, or they can directly post the questions in the chat box.
So herein I'm getting the input from Mr. Vijay Kumar that there aren't any questions.
Okay.
So we go to the last case for the evening, which is case number 6. This is a 75 years old female. This is a late order addition, I think, to the list. The cataract's pretty hard. It's not grade 3. It should be more than that. We'll see under the microscope what grade it is. Exactly. There's a pseudoexfoliation syndrome. The PCVA is 3/60, and we are taking up the left eye for surgery. And the plan is to implant a hydrophobic aspheric preloaded IOL along with Phaco. This is the 700 reading. The delta shown here is 1.82, of course, but I'll just show you the eye trace reading after variant. Variant is normal planning. We are not implanting a toric in this case. And next one. This is the reason why. So there is a significant contribution from the internal side as well towards the astigmatism. So these patients are not really the good candidates to receive toric implants because you can't calculate the corneal toricity, and there is something related to the bag. So since this is PXF, we are expecting a bit of zonular laxity. Let's see how the case goes. Next. On the specular count, the hexagonal cell percentage is pretty low, standing at 26%, but the count is good at 3,769. So they should cancel out each other, and the endothelium should be able to tolerate it.
37 only.
Yeah. Sorry, sir, I didn't get that.
The CV is also
the
good.
CV is
It's
also
only
good.
37.
Yes.
Coefficient of variability.
But
this is the
hexagonality is
ASOC.
poor, sir. It's only 26.
The hexagonal cell percentage wise is yes, but as he suggested, the CV is also pretty tolerable, and you have
Because
the count
the
good. So
hexagonality actually gives us the good potential for future compensation.
True. This is the ASOCT picture, as can be expected.
Quite a
We need
thick
this
lens.
pretty hard and thick. Yes, it is. And then finally, we have the OCT. The OCT was not taken at all. So the scan quality is very poor. The image quality is 2. And so there was no picture shown on the OCT. Stop share. सीधा देखंतु मा मोडे सीधा देखंतु लाइट आड़े सीधा देखंतु सीधा देखंतु लाइट को सीधा देखंतु लाइट को नसी लाइट को टिके तळु करिवा कि लाइट को सीधा देखंतु लाइट को सीधा देखंतु मा तळु करंतु कि बस बढ़िया देखते बहुत बढ़िया देखते ऑफ करो we'll switch off the variant in this case somehow it's not being able to gauge that the eye is perfectly centered. Now this happens if the surface was dry when the initial scan was taken at the OPD, or the other reason for it happening is the eye being too deep socketed, so it doesn't quite it's not able to see the landmarks landmarks in the blood vessels that it used to scan the initial image at the OPD. I do get a drag on the anterior capsule while performing the rexis in the initial part at least. That always gives us a clue that the zonules are not exactly diligent. So
Sudeep sir,
Yeah.
this is Madhu sir. Like this particular case where you are seeing this dense arcus,
Yeah.
what is your experience like in the incision sites? We often tend to get small DMDs. Do you have a similar experience, sir?
No, not really.
Okay.
this one. सीधा देखंतु मा लाइट को सीधा देखंतु So for this expected zonular laxity, I'm going ahead and implanting a CTR even before I start to chop this nucleus. सीधा देखंतु मा लाइट को
That makes sense actually, because when you start removing the bits of the nucleus, the equatorial capsule starts coming to the port without the CTR.
Yes. Yes. So
As
just to
long as
give
the
it an
nuclear
equatorial
bits are
support,
there, it acts as a support. But once you start removing them, that's when the problem starts. And the nucleus rotates a lot better with the CTR in place.
Sir, I think the video is struck.
Paused.
Yeah.
Can anybody hear me?
Yes, sir. Now we are able to hear you.
Okay.
There was a pause
So
in between. I think some connection issue.
Yes, we've had certain weather issues actually here. It suddenly started raining in the evening,
Okay.
so that might be the cause for this. I'm sorry for that. So, do you have the video back on?
Yes, sir. Yes. Now we are able to hear you and see the video also.
Again paused. Yeah. Okay, last please. Over.
The patient is squeezing a lot, I think.
Yeah.
Mhm.
Yeah.
You see it more when the eye is deep socketed. because the speculum are visible. And I don't use the self-retaining for the speculum at all. I always use a wire speculum for my Phacos. I don't use the skewed self-retaining speculum because in my opinion, they exert more pressure on the lids and it's slightly more uncomfortable. So these are very comfortable to the patient. But they also give you less exposure as compared to the skewed self-retaining speculum. So this is where the difficulty might come in because we have implanted a CTR already. So it just traps the cortex and doesn't let it come. So the trick is not to pull the cortex towards the center, pull it radially towards the opposite quadrant like this. So that way, it just exerts a bit of radial pressure on it and they're slightly easier to come out. However, you must be ready for spending more time in cortex removal if you have already implanted a CTR. There's bound to be some amount of trapping, some amount of sandwiching between the CTR and the capsule. So time is the key here. Patience is the key.
Yeah, what I was saying is you implanted the CTR right at the beginning with the nucleus still in place. So at that point,
Right.
it doesn't really trap the cortex so much as it would after removing the nucleus and
True.
implanting the CTR.
True. And it also doesn't trap the cortex so much if this was enough. So this sort of thing also happens at times with lac capsules. The capsule gets engaged in the aspiration port and doesn't come out of the aspiration port if the capsule is lax and it doesn't have an equatorial pull. So wait, completely switch off the machine, wait till the capsule is let go. And if at all there is some amount of traction that you get to see and the capsule is not getting released, then you can push visco from the side port. I was about to do that, but it just got disentangled then. Aspiration level. It's a bit of subincisional cortex there. So we're going in with the aspiration cannula to the side port. So this is where the capsule is the weakest. The bag is the weakest. This is the portion. So I intentionally let it go, left the cortex to be removed after IOL implant. So in the patient profile, initially, before starting the case, there are a lot of things I told you. The thing that I did not tell you, and you also can see bits of cortex that have escaped through the zonules into the vitreous cavity, into the anterior vitreous cortex. So that also suggests that there was zonular laxity. So what I did not tell you was this patient is one-eyed. So that just put an additional bit of responsibility on me to ensure that the surgery goes well in this eye because the other eye is not there. So we have a practice of putting in some povidone iodine on the surface in all one-eyed patients before the patients asked to get up from the bed. Apart from the intracameral MOXIE, this is our practice for all one-eyed patients.
Why not in all the patients? I use it in all the
Yeah,
patients.
yes, but at times it just causes a bit of congestion, sir. It doesn't stay for long, but
Yeah.
yeah, I mean, you can also use it in all cases. So we're through with the surgeries lined up for the evening, sir. If there are any questions or any discussions, we would like to, happy to take them up.
Hello, can you hear me?
Yes, Praveen, finally.
Yeah, well, it was a wonderful experience seeing you operating and so many learning points. I just want to see the monitor of that machine.
Which machine? The Phaco
The
machine?
yeah, the Phaco machine. How I have never seen it, so I want to look at it. And what
So
are the
admin, can you
parameters?
spotlight? Yeah, I'll just show you. Admin, can you spotlight the other video of mine, please? Coming in from the mobile phone. Can you please spotlight that for everybody?
Can you please explain the parameters which you have?
I will, Praveen. Just let it come on the screen, then I'll do that.
Yeah.
Admin, can you please help us?
Yes, sir, done.
I can't see it. I can't see my own video on the screen. Have you spotlighted it?
Yes,
So we
doctor,
can
it
see
is
the machine.
spotlighted. Yeah.
Okay, fine. So Praveen, this is
for the last case. For the last case, what was your parameters and what did you?
This is the same parameter I use for every case. So this is for ultrasound 2, the chop mode. Essentially, this is 50, the power amplitude. This is aspiration flow rate. This is non-linear, so this is in panel mode, 33, and the vacuum was 350 for all the surgeries. For the quad, this was the setting. The power remained at 50. I was thinking about increasing it to, I mean, in the chop mode at least in the last case, but I think it did a fair job. So since I got the crack at the first course, so I didn't raise the power. This is not needed. So this is US3, the quad mode. 50 remains as the power, linear, non-linear AFR at 37, and vacuum at 360. This is what we use for all the cases.
Did you reduce the flow rate in this case, last case?
No, I didn't.
No.
I didn't.
Is it preferable to reduce it? Hello.
What about the intraocular pressure? Is it showing there range?
No, this is a gravity fed machine. So it won't show intraocular pressure.
You don't have this IOP.
No.
Okay.
The full version of the same.
Galaxy Pro or which?
Your voice is not coming, Anurag. Anurag, we are not able to hear you.
Sorry, I was muted, friend. Sorry. So where did you lose me? In which part? Okay. So this is the ultrasound 3, Praveen. As you can see, 50, 37, and 360. And this is the mode Dr. Madhu was also speaking about, the O-pulse mode. O-pulse means that it's a continuous phaco energy till you get to the occlusion point. When you get to the occlusion point, the machine changes its power delivery to pulse mode. You can also have O micropulse. Where is that? So this is O micropulse, wherein you have the delivery in the micropulse mode. Pulse and micropulse both are available. You can also customize the count, the number of pulses you want in a second, and the on time and off time. That also is customizable in micropulse. The on time is not customizable in pulse mode. So
my question is, do you customize in each and every case, or it's just whatever the parameters are set, you do it in all the cases?
So you can customize. I didn't do it in this
So in the
particular
last
session.
in the 6 cases which you performed, you did not change anything. It was the same.
No, I didn't change anything. It was
Yeah.
the same. Yeah,
Okay.
it was the same. I didn't feel the need, otherwise I would have. So this is the infusion bar. You can change the infusion line, the bottle height to your need. So I kept it at around 100 centimeters. It doesn't show the height, of course, but it is around 100 centimeters. You can also go down if you need less fluidics in one particular case.
And what about the power in the hard cataracts in the last case, as the nucleus was around grade 4? Did you increase the power, or it was the same?
No. It was 5 only. It was 50 only. I didn't increase it.
Okay.
I did not increase it. But you can. I mean, I have tried with 60. I have tried with non-linear mode of power delivery as well. Since this is a 15-degree tip, I'll just show you the tip. This is a 15-degree tip actually.
Okay.
Or 30-degree. So this is a 30-degree tip. If you increase the bevel to 45, it will increase the cutting efficiency. So you can maybe go down on power a little bit and keep the vacuum the same. But what I would not recommend if you're using this machine is to go up on the vacuum level beyond 400. So that might just be risky. That might just be causing a bit of surge, particularly when the nuclear pieces start getting emulsified and start getting absorbed. So 350 to 400 is the comfort range. And I think we saw enough examples tonight to suggest that we don't need beyond 350, 360 in most of the cases. In most of the cases.
So on the lighter side, in the rating of 1 to 10, what will be a rating for this machine?
Every machine, every equipment in the industry has to be gauged with regards to its performance, its comfort to the surgeon, and definitely the price point. So considering all that, I'll give it a spot on 10 out of 10. All that concerned. There are variables, yes, but it's a 10 out of 10 when you consider parameters, and you have to consider parameters. You can't just judge the machine. To have a proper apple-to-apple comparison, you have to take all these things into consideration before judging a machine. So if all these three things are considered together, it's a perfect 10 on 10 for me.
Looks quite handy.
Did you experience any form of surge during the last piece, or it was bang on the stability?
So I did experience that in one of my OTs when I scaled the vacuum up and took it to 450. I was over aggressive, but in that case, on that day, I did experience a bit of surge. But otherwise, routinely, I haven't. It's been.
We didn't see that today at all.
We didn't see it all.
That today.
Exactly, we didn't see it all.
Camera was very stable. All
true. We did not have the chance. Yeah, so I was talking about the grip of the handpiece. So this is the handpiece. Just wanted to show this to you. Just looks like a pencil, maybe a little thicker. But I love this grip out here. So when you hold the handpiece, there's no chance of it slipping anywhere. Of course, it doesn't slip from most of the surgeon's hand. But I'm just saying that the ergonomics of this part, which is slightly like a dumbbell, slightly narrow at the center and broader at the ends, and there's this cobblestone appearance, this honeycomb appearance, this squarish appearance of the grip. So it gives you a very good grip, and it's very, very light indeed. Hardly 35 grams. Very, very handy. Very, very light.
What is the cost of the machine?
About 13 lakhs is what they say.
Is what they say.
Anurag.
Yes, sir.
Anurag.
Yes, sir. Good evening,
yes,
sir.
Sir. How are you?
Sorry, I'm fine, sir. How are you?
No, I was watching your surgeries.
Right, sir.
It was really fantastic, immaculate surgeries, I would say. Hats off to you.
Sir.
And
Thank you, sir.
sorry, I couldn't, because the Times healthcare function was there, and just now it got over, so I couldn't talk. But I was continuously watching all your surgeries. Very good. Hats off to you. Immaculate. Yes.
Sir, we would all join in.
You are used.
We would all. So you looking dapper as usual, and we all join in to congratulate you from the bottoms of our hearts may you touch the sky, sir, in terms of success. This is a big moment. I think we should all clap and laud your achievement that you received tonight.
Thank you, Anurag. And you are using the Leo Galaxy mission.
Yes, sir.
Which mission you are using? Leo Galaxy mission.
Oh, this is
So,
not
This is
the
a
Leo.
Galaxy.
This is the
because I want
smaller
to
one.
look
It's not the Leo, the Galaxy
Not
Pro
the Leo.
Orbit.
Galaxy Pro Orbit. Okay, whatever it is. I've been using this and I performed live surgeries across the country using this machine. This machine, I will tell you, for the benefit of other panelists and also all the delegates here, it's like a workhorse. It's really fantastic machine. The chamber stability is very good. The active fluidics is there. All the features what you see in Centurion, everything is available here with all the top-end machines. And more importantly, I think is what you call the backup service is something which is incredible. And that's what I tell Appasamy people wherever I go. Throughout the world, we have done Appasamy surgeries. Even in Russia, we have done in the Middle East, I'm sorry, in Africa as well. And all the places, I always used to tell that Appasamy is probably the only guy I think we should congratulate Appasamy people for bringing quality eye care technology to us at the most affordable cost. And that's the reason why in the Tamil Nadu Ophthalmological Association, we recognized Mr. Appasamy and Mr. Kasturi posthumously with an award during the Tamil Nadu Ophthalmic Conference 2 weeks back in Coimbatore. So, whatever I could see, that the surgeries, of course, the man also is very important. But more importantly, I think it is the mission also is something which is very important because we can concentrate on other aspects of surgery, and the mission stability is something which is really phenomenal. And hats off to you, Anurag. Wonderful surgeries.
Thank you so much, sir. Thank you. So, any remarks from the other panelists?
And regarding the lenses, I think you have demonstrated all the lenses, no? What are the lenses you demonstrated today? Anurag?
Sir, we lost you, sir. We couldn't hear you.
Hello?
Sir, we couldn't hear you, sir. I couldn't hear you, sir. Can you please repeat the question?
He was asking about the lenses. Lenses you used.
Yes,
Yes.
sir. What are the lenses you
So the
demonstrated
lenses we
today?
used? So the lenses with the toric,
Toric okay,
monofocal toric, one multifocal, one
Yeah.
in focus, one super foam, and one suprafoam.
Absolutely. I think the entire range is there with Appasamy, which is for everybody to see. And the long-term results are available with InFocus. We have published papers also. And it's one of the best EDOF lenses I ever seen. And with absolutely no photic phenomenon at all. And very affordable cost to all the patients. So I offer InFocus to all the patients who cannot afford otherwise the costly multifocal lenses or the EDOF lenses. I want the experience of other panelists on this InFocus lenses, which is I think one of the best lenses in the entire armamentarium of Appasamy.
I agree with you, sir. We also have used a number of InFocus lenses, and results are so far very good, even especially with needs of night driving and all, as you have highlighted, no photic phenomena at all, sir.
I only wish the Appasamy people bring the InFocus in the preloader platform. So we don't have the preloader platform for InFocus as yet. But all other things, we got the preloader platform. And only I think InFocus, I think very soon will come out with the preloader platform as well, which is going to make our life very, very easy. And FOB is also very good. and the hydrophobic platform is really fantastic. The suprafoam and the toric lenses are very stable. Rotational stability is very good, and the multifocal lenses are also fantastic. So having worked with Appasamy for more than 20-25 years, so I know how they have grown from scratch and brought, and then they are in the cutting edge of technology, I would say. And whatever is available, they'll bring it here. I'm sure. Before, no, we used to have. I think your microscope also used was a brilliant or advent. Anurag?
No, he used a Luxor. He used a
Sir, the
Luxor and Appasamy
Okay,
microscope.
okay. Microscopes are also very good. The microscope of the Appasamy, and now I was using the 3D. We are getting the 3D again of Appasamy, which is in fact we had a demonstration of the first 3D in RAO GOH in Chennai a few months back in December of last year, and the 3D is fantastic. It's equivalent to the RTO system. I've operated an RTO system. I've operated the Ingenuity, but the 3D of Appasamy is also very good. They made one of the most important advantages of Appasamy is that they do continuous introspection. They do continuous introspection, and they try to raise the bar now and then. I think the R&D is very good, and initially when they brought the 3D about 2-3 years back before the COVID, it was not so good. There are a lot of lapse of time. Time lapse was there, a lag, or the time lag was there. But now I think the 3D is much better than any other 3D which is available there, and it is really very, very good. And the microscopes have also improved. The Brilliant, the Advent microscope, they're all very good. Very good red glow is there available. Very good illumination, and of course the cost is 1/5 of the cost of whatever you are having with the other top-end microscopes.
Yes, sir. Even I had a good experience with their 3D systems.
Yeah.
I have done a complete keratoplasty, sir. 16 sutures.
Amazing.
Heads up surgery, and it was excellent, sir.
Yeah, yeah. I know that Madhu is such a fantastic corneal surgeon. Even without anything, any microscope, he will do a corneal transplant, closing his eyes. And because the genes are running in him. Madhu, really hats off to you. But the 3D is really, I think, the way to go in the future. But I'm just talking to the Appasamy people to make it a little more cheaper so that it can penetrate the market much better. 3D, very, very easy. If you start using the 3D, it makes your life easy, it makes the surgery easy. And people who get trained also, my postgraduates, they also found the 3D was much easier than the regular one. And even the teaching, everything is so easy in 3D.
Yes, sir, it's an excellent teaching thing because quality is not compromised. Everybody gets 100% input.
That is right. Teaching also, and the training also. The people who get trained on 3D, they adapt very fast. In fact, when we had the 3D for a few months, we found that the postgraduates, the beginners, and our consultants also, they were able to do the surgery much faster than our regular the microscope or the regular this thing. So I think the 3D is got a huge advantage. Only thing is, if they are able to reduce the cost further, it will penetrate the market much easier and make the benefit go to everybody. Yeah.
I think it is time now to close up. If there is no question,
yes.
I request Dr. Santosh to give vote of thanks and we'll end the session.
Thank you, sir. Anurag, I think for the first time today, I regretted not being a cataract surgeon after seeing your surgeries. So I'd like to thank Appasamy to provide this platform, and on behalf of Odisha State Ophthalmological Society, I'd like to thank all our guests like Dr. Mohan Rajan, Dr. Madhu, Dr. Sudeep, and all the panelists who have contributed to this scientific discussion, and the surgeon who has really stolen the show for the evening. It was very good surgery show as well as discussion. I hope everybody has learned. I'd like to thank one and all for this wonderful meeting. Thank you all.
Okay, good night,
Thank you
everybody.
so much. Thank you.
Good night,
Good
everybody.
night.
Thank you, Santosh.
Good night. Good night, Mohan sir. Good night, Madhu sir.
Night.
Good night, Sudeep sir.
Once again, apologies for the delay in getting into the webinar. Thank you very much.
Thank you, sir. Thank you for joining us.
Thank
And
you.
congratulations again. Thank you.